Hi, my name is Lasse Friis and I'm a student of the International Academy of Osteopathy. And in this video I want to present my data from my scientific article. And the topic was manual visual manipulation of the sigmoid colon on women with slow colonic transit and diagnosed with unspecific low back pain, measurements done for pain before and after the treatment using the visual analog scale. Just a summary of what I'm going to talk about in this video presentation. First, I would like to start off with the background and the objective of this study. Then I will introduce the material and my use of methods, then the results, the discussions, and I will end up by doing the conclusions. My personal background to obtain this study was based on my personal experience concerning these patients with slow colonic transit. Low back pain is a common health problem which osteopaths and manual therapists often treat. 80 to 90% of these patients with low back pain are diagnosed with non-specific low back pain. The sigmoid colon has a fascial connection via the iliopsoas muscle, which attaches on the lower back. Patients with slow colonic transit may appear with tension and retractions of the mucosal wall and the peritoneum in the surroundings of the colon. The hypothesis was if tensions could pull on these fascia to the low back spine, which might be the cause of the pain. The aim or the objective of this study was to figure out if there were any connections between the sigmoid colon and low back pain in females diagnosed with slow colonic transit. This study was conducted as a quasi-experimental design. The procedure was done by pre- and post-testing 8 patients who all had lower back pain and at the same time was diagnosed with slow colonic transit. The aim was to measure the pain level before and after by using the visual analog scale. And as you can see on this figure, it's listed in the right order of the interventions. The visual analog scale was used for measuring the pain in a subjectively manner. The test is used commonly to point out the pain intensity by a number from 1 to 10. The measurement was done by creating a 10 centimeter line on the paper, as you can see on this figure, who had no indicators on it. On the left side was written no pain, on the right side worst pain. Before each treatment session, the patients were asked to point out their subjectively pain level on this paper note. By drawing a perpendicular mark on the line that represented the pain level, the intervention was done before and after the first treatment and before and after the second treatment. All 8 participants are shown on this scheme here. They were all listed by age, height and weight. After that, the body mass index was estimated. As you can see on this table, the VAS score is represented before the first treatment and after the first treatment. And then again, the VAS score before the second treatment and after the second treatment. The intervention consisted of 4 visual manipulation techniques, and each technique was performed between 4 to 5 minutes at least. The whole treatment session was approximately 16 to 20 minutes. All were performed twice and took place in March 2016. There was a week in between the two treatment sessions. All the techniques are listed here on this scheme. As you can see on this figure, it shows the statistical tendencies between the measurements. There's one before and after the first intervention, and thus 2 before and after the second intervention. As you can see on these tables, these study results showed a strong significant p-value on 0.0004 between VAS2 before and VAS2 after the treatment, with improved mean range by 2.4375. The same correlation was found here on the second table in VAS1 before and VAS1 after, with strong significant p-value on 0.0017 and a mean score difference on 1.8625. On the last table you can see the VAS2 before and the VAS2 after treatment, and it showed a strong significant p-value on 0.0358 with a mean difference on 6.625. As you can see here, VAS1 after and VAS2 after was also significant with a p-value on 0.0464. The only non-significant p-score was the 0.8606 was VAS1 after and VAS2 before. The regression analysis showed only one possible similarity between VAS, age and body mass index, but the correlations were unknown. This study couldn't exclude any significance of other factors, as for instance the psychological relaxation on pain after treatment. These results could be inflected by several biases, as for instance the absence of control group. Stockdale et al. Confirms that an examined population should be a variety of both study and a control group. Another bias was the lack of randomization that creates less credibility to internal validity. There was also a variation in the composition of the population compared to age. Robinson et al. Stated that the reliability could be vulnerable to the composition of the target population if the variety was too high. Another bias was the correlation to the accuracy of reproducing the same study results, because the practitioner did both test and treatment sessions. Peterson-Håkansson mentioned that the validity would increase significantly proportional to more population. This study only consisted of 8 participants. A possible bias was also that you couldn't exclude any psychological stress in the selected group. Emotional stress could be hard to distinguish from non-specific low back pain. A specific mobility test was used for evaluating possible tensions and restrictions around the sigmoid colon. The bias was that this was subjectively evaluated by the practitioner without any kind of measuring tool. There may be a need for a much larger study to confirm and secure these findings. This article could be used as a template for future experiment, for example an RCT study with blinding of the participants and a much bigger control group. The goal for this study was to clear out if there were any connections between low back pain and slow colonic transit in patients with sigmoid tensions. The sigmoid was treated with visual manipulation and the pain level was measured before and after with the visual analog scale. This study had a strong statistically significant outcome and showed a pain reduction before the first intervention to after the second intervention. The p-value was 0.0004. These study results can conclude with statistical significance that osteopathic visual treatment can reduce low back pain in patients with slow colonic transit. The long-term effects were not investigated in this study. Results of this study needs additional investigations about this topic with a much stronger study design.